Hello, everyone. We're going to get started with the next part of our session. My name is Mahasin Mujahid. I'm an associate professor at UC Berkeley. I am introducing this next panel. The panel is going to cover the role of precision medicine and health equity research. I think it's definitely a topic that's on everyone's mind. Anytime you hear something about precision medicine, those of us that consider ourselves the rebels are like quick to say, well, what about disparities? And what is it going to do for disparities? And so we get to hear from some experts in the area who are critically thinking about the role that precision medicine may play in disparities and how we can have some accountability around making sure that we think about potential consequences or unintended consequences of precision medicine in relation to health disparities and health equity. So I'm going to turn it over to my co-moderator to introduce our panelists. And the way we're going to do is she's going to introduce the panelists. Each panelist will give a 5 to 7 minute overview of some comments that they have prepared on the topic. And then we'll have plenty of time for discussion after that portion of the session. Thanks.
Hi, everybody. I'm Jennifer Smith. I'm an assistant professor here at the University of Michigan. I am a genetic epidemiologist, epidemiologist by training, and I'm really interested in the intersection between the biological and the social predictors of health and health disparities. So I'm just going to introduce our distinguished panelists. So Eliseo has already given you a very nice presentation this morning, so you know him. And Diez Roux. You all know her as our fearless leader of CIAD. She is also Distinguished Professor of Epidemiology and Dean at the Drexel University Dornsiff School of Public Health. And as you know, she's an international leader in social determinants of health, multi-level analysis, and neighborhood health effects, particularly in cardiovascular disease. James Jackson couldn't be with us today, so we're skipping him. Carlos Mendes de Leon is our CIAD leader now here at the University of Michigan, which is great. He's also the director for the Center for Social Epidemiology and Public Health here at U of M. He was previously at Rush University and at Yale, and he's a social epidemiologist with a primary interest in major health problems and health disparities in later life. So age-related health outcomes, disability, and cognitive decline are some of the things that he is really interested in. And finally, Sharon Kardia, last but not least. She is Senior Associate Dean for Administration here at the School of Public Health. She's a professor in epidemiology, and she is now, in the last couple of weeks, named the Millicent W. Higgins Collegiate Professor, so we're very proud of her for that. She's our resident genetic epidemiologist. She studies cardiovascular disease and also gene-environment interactions and statistical genetics in common chronic diseases.
All right, so we're going to go a little bit out of order. We'll begin with Carlos. So we'd love to hear your 5 to 7 minute overview. Thank you.
Thank you, Mahasin and Jennifer. And as indeed, as you said, as co-PI now of the CIAD program and center grant, I would like to extend another warm welcome to all of you, especially for those of you that come from out of town. I hope you are enjoying this meeting like we have in the past. And I also would like to take this opportunity to thank Dr. Perez-Stable, as director of NIMHD, for all the support NIMHD has given to this center. We are very, very grateful for that, and hopefully you are enjoying your visit and see that your NIMHD dollars are well spent here. We'd like to think they are. Anyway, I just want to make a few more general remarks on our topic of the role of precision medicine and health equity research. And I would start, and this is why I requested to go first, to read out the definition of precision medicine as it is posted on the NIH website. Precision medicine is an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each person. This approach will allow doctors and researchers to predict more accurately which treatment and prevention strategies for a particular disease will work in which groups of people. It is in contrast to the one-size-fits-all approach, in which disease treatment and prevention strategies are developed for the average person with less consideration for the differences between individuals. So from a health equity perspective, what is potentially good about this approach? And there are probably a number of things we can think about that could be very good for a health equity perspective. And so one thing that I was thinking of is that perhaps this gets away from defining risk and outcomes in aggregates, defined, for example, by race ethnicity. So it seems, for now at least, to move away from the concept of race ethnicity as a biological construct. Pathology in humans is governed or produced by the same biological or molecular principles encoded in the unique DNA of each individual and operates through the same protein encoding mechanisms, and then further understood in terms of precisely defined other omics pathways, metabolomics, proteomics, etc. So the need to understand disease risk and disease outcomes as a function of race, ethnicity, ancestry, country of origin may cease to exist, or so it seems at least. But from a health equity perspective, what are the potential challenges and critical issues in thinking about the role of precision medicine? First of all, we all realize, and I think the advocates of precision medicine, of course, realize the same thing, and it is certainly captured in their definition, that these biological mechanisms do not function or operate in a vacuum, in a human body that lives in isolation from its environment. In fact, there's plenty of reason to believe that these biological mechanisms function in response to those environmental exposures. In fact, they are designed that way and have evolved that way if we still put some credence in evolution theory. So perhaps we can start to characterize this environment, our environmental exposures, in precision terms as well. That is, everyone is born, grows up, and lives and ages in his or her unique environment. And our task is to define and characterize that unique environment using the same basic approach as geneticists wish to define everyone's unique genetic structure and its functional or molecular outputs. But is that a realistic, let alone a cost-effective approach? Is it not more efficient to think of ways of characterizing environments that groups of individuals share in common? That has certainly been the approach of public health and epidemiologic research so far, and it has led to plenty of very useful insights, also with regard to understanding health disparities. The merits of this way of thinking has been well articulated by scientists such as Mu and Curry and others, who have offered the term of precision population health to capture this idea in juxtaposition to the term of precision medicine. Second, perhaps we start seeing a growing appreciations for the more unique aspects of this environment, that is, defining health risks and health solutions at increasingly more local levels. An increasing attention to the local setting, the local set of interrelated exposures that affect communities and the individuals that make communities in relatively unique ways. Yes, there may be many communalities across communities, say neighborhoods, but the real challenges and the real solutions are best achieved at the smaller spatial or geographic scale, rather than at a higher aggregate total population scale. In that sense, the idea of precision medicine, or better, precision public health, has already entered the stage of our research, and approaches to think innovatively about solutions, and especially solutions to finally start reducing and eliminating intractable health disparities in the US population. And third, whatever the goals and achievements of precision medicine will be, health equity is served only. And it is served only if the benefits are made available to all and are shared in equitable ways, where everyone, without regard to race, ethnicity, social status, education, income, insurance coverage, has equitable access to the fruits of the screening and prevention or treatment modalities that emanate from the precision medicine investments currently underway. I think in the end, we do well as a group of researchers and engaged citizens to follow closely the progress that is made in precision medicine. I think precision medicine has a lot to offer to inform the origins and the solutions of health disparities. And I think we do well to try, as Dr. Perez-Stable mentioned earlier, to try to get a seat at that table in that conversation. At the same time, I think we should never ever shy away from making our own expertise available to the community of precision medicine researchers. I was a little bit involved in the beginnings of the assembly of this precision medicine cohort that is now underway. And while there was clearly an intention to recruit this 1 million people cohort, precision medicine cohort, to make that as diverse as possible, at the same time, I was not very impressed by the attention to or interest in the critical social determinants to incorporate in that in some fashion or another. So I think our task will be to make sure that our voices are heard in this conversation, and I think this should be our mission for the next 5 to 10 years, so that we can benefit from each other as equitable partners for the common goal of reducing and eliminating health disparities. Thank you.
Great start.
Go ahead. Okay. Let that social epidemiologist.
Okay, we'll have the social epidemiologist first. So my comments will parallel many of the things that Carlos said. So I have 4 points that I want to touch on. What is precision medicine? How do we know when we see precision medicine? How does the precision medicine approach differ from the public health and population approach? Is there common ground? And a brief research and action agenda. So in terms of what is precision medicine, I also found the same definition initially that Carlos read to you, so I won't read that back to you.
Sorry.
But I did also, no, that's fine, but I did also find the what most people will probably read, which is Wikipedia. And I
skipped that one.
I think Wikipedia is probably capturing the subtext of all the definitions that are out there. And Wikipedia says, a medical model that proposes the customization of health care with medical decisions, practices, and/or products being tailored to the individual patient. So it's about medical care, health care, being tailored to the individual patient. And I think that's probably what most people think when they hear the word precision medicine. Although it's true that in the White House initiative, certainly it's formulated in a much broader manner, but when people really think about it, this is probably what they're really thinking about. And there are 3 key elements here. One is a focus on health care. And treatment specifically, and treatment in the narrow medical sense, not treatment in the way that social scientists talk about treatments, which is interesting in itself. The social scientists have used the word treatment to identify interventions. It's a medical term, actually. But a second is that it's about tailoring to the individual. And although certainly we can think about tailoring to the individual in a very broad sense, I would argue, to be maybe a little bit provocative here, is that there is a bias towards factors that characterize individuals and differentiate individuals from each other. And the paradigm of that is genetics, right? And the precision medicine movement, and that makes sense because the precision medicine movement was heavily influenced by precision and cancer treatments, which is about very appropriately about targeting treatments based on genetics of tumors, not necessarily genetics of people, genetics of tumors, and that makes a lot of sense. So this is the individual level factor par excellence, if you want to think about it, right? Because we have commonalities, but we're all different. And this is this sort of individualization of risk thing, this thing, well, let's find the risk predictors, things that can differentiate each individual, and let's predict risk based on those individual risk characteristics. And a correlate of that is that the implications, if we're all different and we all need different kinds of treatments, then the implications for action are very individual based, right? They're about things that focusing different things that we do to people or have people do, right? And this may be, all these things may be very important in terms of medical treatments and very necessary. And when we think, and these interventions, individual interventions, if we follow sort of the rationale, they tend to be divorced from the social and other contexts because it's about something about the individual. I realize that this is the extreme, definition of precision medicine, which is more the traditional one, but I think it's good to talk about that one too, because it's kind of the origin of it, and we can think about broadening it. What's the population health approach, and how is that different? Well, population health, or public health, is all about factors that influence distributions. Remember Jeffrey Rose, right? That's what it's about. And the idea that focusing on factors that explain only inter-individual differences may cause us to lose important drivers of health, important things that we can intervene on. And this is particularly important because a lot of the issues that we deal with in disparities are about intergroup differences. And so we need to focus on drivers of patterns and population differences to understand causes and to figure out what we can do to reduce those disparities. I would argue, though, at the same time, I've laid out sort of the precision medicine as sort of the individualized treatment approach, and the population health approach is a more macro approach. In a sense, this is a false dichotomy, because in reality, we know that individual level characteristics are, at least in part, product of the environments that people are in. I'm going to use the term environments here to be very broad: physical environment, social environment. We know that environmental factors modify the effect of individual level characteristics. We know that this is happening for genes, even though it's really hard for us to pick it up. We know it's happening all the time. And that these are systems, right? That environments affect people, people affect their environment. So in some ways, trying to separate these things out is very artificial. So is there common ground between precision medicine and the population health approach? And I think there is common ground. So if you want to be precise in understanding how individual level characteristics affect health, you need to consider the environment, even if you're thinking only about individual level predictors. In order to understand how they work, you need to understand their context, because their context modifies the ways in which they work. If you want to be precise in predicting outcomes for individuals or tailoring treatments so that they are most effective, I say you need to consider the environment too. If you want to understand population differences, you need to consider the individual characteristics as well. So in fact, these things are false dichotomies. They need to be integrated. So this brings me to my last point, which is about a research and action agenda. So I think there's a lot of room for integrating these things. And I think in many ways, it's interesting. It's interesting for me to reflect on this, because this is the way we started the CIAD. It was about this, exactly, right? Remember, Sharon and I had a little conversation in Boston in a meeting that we were both at, and this is exactly what we're talking about. So, and I think now we also, because there's this interest in precision medicine from the medical world, we have an opportunity to start building more connections between the medical world and the public health approach. And so, what's the role of the environment in clinical prediction? I mean, I think clinicians are very aware of this now, that there are environmental factors that they can use to predict clinical outcomes, to help inform treatment decisions and to predict treatment outcomes, to identify what treatments are most likely to work in which people. But for that, they need more than biological characteristics. They need the environmental factors. Also, a related research agenda question has to do with the role of non-medical interventions on treatment outcomes. So what if you treat people in a context, so you treat diabetics in a context where there's a sugar-sweetened beverage tax? How is that different than treating diabetics in a context when there is no tax? And so these are true multi-level interventions in the broadest sense, where you're really intervening at the level of the patient, but you're also intervening at the level of society. And I think the role of these multi-level interventions in health disparities and figuring out which ones are really effective, I think is really the big research agenda, continues to be the big research agenda for health equity and for health disparities, and is where there can be a real confluence between precision medicine in its most traditional sense and the population health. And the last thing I'll say is that, if we think of precision as something that's accurate. And we think of medicine, we broaden medicine to incorporate all we do as a society to improve health, to treatments at the individual levels and policy. I would argue that precision medicine is nothing more than evidence-based public health. But that's just something that, since I'm a public health dean, these are the things I say. And in fact, precision medicine is a subset of evidence-based public health. So that's
Well done. Can I use that? We should. So this is a hard act to follow, and at the risk of sounding a little bit like the geneticists in that study section, I'm going to take a moment and actually sort of reflect to this group some of the challenges with the current vision on precision medicine, and then sort of pull us back into the more evidence-based public health. So for over 20 years, I have worked on gene-environment interaction, on the genetics of common chronic diseases. We do great work with dozens and dozens of other cohort studies and consortiums to identify genes. And there are ways in which right now is, in a sense, a pinnacle of a revolution in genomics. Our ability to understand genes and their influence on the human body has never been better. That said, if anybody really looks under the hood, and the geneticists know this, when we look at all the genetic information underlying a particular trait, and we put it into the basic idea of like, well, how much variability is it explaining? It's teeny. And it's depressing. That
Not surprising.
Well, and some of it actually has to do with the fact that human beings are highly variable. We are not very homogeneous in our genomes. Everyone has millions and millions of mutations. So to be able to see one mutation's effect shining through all the environment and all the other mutations, it's small. And so there's a huge challenge in this precision medicine for what I think of as the dream of better sort of identification and treatment and then better outcomes. Cancer, it really does make sense because cancer is a genetic disease. Something goes wrong in the genome and you can actually see it in the tumor. But for human beings that are coming in and presenting with all sorts of symptoms, it could be anything. And so, you know, there's a lot of challenges that are going to go with that. And, you know, we're human beings, which means we learn the hard way. There's not an easy route to the knowledge that we gain. There are, I'm going to say, probably something on the order of 5,000 to 10,000 known very strong genetic factors that we should be integrating into medical care. But some of them we already know from inborn errors of metabolism. Some of them we know from inherited cancers, you know, pharmacogenetic sort of adverse reactions. So we actually know a lot, but they tend to affect a small number of people, 1%, 2%, 3%. Now, if you scale that up to millions, it actually does matter. And so we should be using the knowledge that we have in that context. But I think that's actually one of the easier parts of this. And I think what is much more difficult is the integration of the environment, which has been a part of that vision, and has some, I'll call it, additional cautions, at least for me, as people talk about integrating social determinants into, for instance, a physician's view of somebody, where the stereotypes could just sort of multiply. And clearly in the way that the Affordable Care Act has sort of stimulated new innovation for people to look at population health. I don't know, much to my dismay, many hospitals have taken that on as if they do population health. They've got directors of population health. They've got, it's like, oh my gosh, well, what are you doing for population health? Well, we're watching it. So I want to tell you a story that was pivotal for me, and I think actually represents some of what can happen. So last year was a confluence of things that sort of opened up my eyes to new opportunities. One, the university gave the Tommy Francis Global Medal Award to Sirfazi Hassanabed, who's led BRAC, which is a nonprofit that serves over 120 million people in 20 countries. They've created 45,000 schools. They've created tens of thousands of banks. They've raised the infant mortality of numerous countries, and all with the model of actually working more on the structural elements, the structural inequalities that undermine health inequalities. So just being near this gentleman and how he could take these ideas and use the principles of health to motivate people through sort of community health structures. Where simultaneously I'm also asked to be a reviewer of parts of the precision medicine applications. And I'm looking at these and I'm thinking, oh my gosh, they really want the same thing. They want the world to be a better place, totally different approaches. Then the MacArthur Challenge came out, the 100 and change. I don't know how many of you saw that. But here we've got an institution that's willing to put $100 million on the table for somebody to scale up an idea to really make systematic social change. And because of both my own personal background and then the work in the social determinants, for me, poverty is that #1 thing. That if I could change anything, it would be that. So I started working with the Poverty Solutions group here, as well as doing some other work. And while that's happening, the U of M Precision Medicine Initiative changes to precision health. So they make a systematic shift away from medicine to this health paradigm. They bring in engineering with medicine, with public health, with pharmacy. They'll add social work, they'll add others. And that was a signal to me that the tide is changing, that we're now actually working together. And wouldn't that be actually the best outcome if we could pull the best of these disciplines together to actually make a systematic change? And I think that those pieces actually set us up for being much more aggressive on some of these ideas of precision population health, because the precision medicine people need their corollaries. Because if they're going to make an impact on opioid dependency, it's not just the scripts, it's what's happening in the family afterwards. It's what's happening to the pills that are already there. And we've got to build that bridge. So the last piece of this was another, I'll call it nice twist of fate, is that we started an innovation studio here that would bring interns from across the university to work on basically a big problem. So I said, great, I've got one. It's poverty and population health. And so here are the, right? So how could we actually do precision population health? So it had health informatics, it had a person from design, it had a person from the Ross Business School and from the Sustainability Institute. And they interviewed people across the country, from sort of the community benefit officers at nonprofits who are motivated to actually show improvements in population health, to people in the sort of leadership of Kaiser Permanente, local public health. And what they came up with was a prototype that would address people's needs to get information on their locale about the prevalence and incidence of disease, so they could actually see areas where there were these health disparities. And what was mapped with that was the social determinants. Plus this other piece, which is how do you motivate change? So if you put then health economics, and we started working with faculty in the health management and policy to show the cost of that health disparity, and then what would it take to actually intervene on it? For instance, to create sort of models of how institutions in a community could become anchor institutions and actually through a systematic way change some of the structure of their community. That it became one of these things that everybody they talk to says, I want that. Now, when you've got people across the country that are wanting the mapping, the access to that information, the facilitation of using it, that speaks to me that we're on sort of the precipice, but we need actually all of those different disciplines to come together like never before. And so I would say actually it's the time for more interdisciplinary work to really push that evidence-based public health into the hands of people who can make the change. So thank you.
Well, I already had my time, but I'll add a few comments. At NIH, the Precision Medicine Initiative name changed to All of Us. It's an All of Us research program.
All of us?
That's what it's called.
Can't really tell what it is.
Eric
All of us is.
Eric Dishman is the CEO, the director. Eric actually came out of industry. He was sort of executive at Intel. And Francis Collins recruited him. I interviewed him before he was offered and accepted the job, and I was taken by him. He has a remarkable personal story in that he had kidney cancer that was not curable, but kept getting treated. And then he was reaching the point of dialysis when somebody said, well, why don't we genotype the tumor, as Anna was highlighting. And he had a remarkable response to immunotherapy and then was successfully transplanted. So, and he talks about his personal health issue, and I think it gives him a lot of credibility with populations. So I feel that it's in a good place to do all the things that we just heard. Eric's perspective, he doesn't have a PhD, although I think he was in a social science path before he went into Intel. He runs big programs, and the launch of precision medicine is probably not going to be till this fall, unless something happens to the funding. You know, they've done awards, as you well know. There's academic centers, clinical centers, and 6 federal qualified health centers that have been awarded, and they will the NIH will also sponsor a website that will actually, people can volunteer and go to it. So Francis himself has said this is not a genetic study. So the origin of Precision Medicine Initiative may have been that, and it still is an important component of it, but it is not what it's not what it wants to. It's actually a huge cohort study like the United States has never done, but not with the detailed kind of, you know, in-depth vertical data collection that we're used to, like Framingham or Jackson Heart Study or MESA or other cohort studies. So I personally think it's extremely exciting. I didn't know anything about Precision Medicine Initiative until I got to NIH. Didn't pay any attention to it. But it's a huge opportunity to do systematic data collection, whether it's 1 million or 500,000 or 1.5 million adults, and eventually they'll get children in the U.S. With all of this baseline beautiful data collection that we can then use to look what happens after a bunch of years. So it is your dream research platform if you're thinking in those terms 10 years from now. And that's where we should be thinking about it. So in order to make this work, one has to do the basic things well. And I think that we've done all that based on all the efforts and huge amount of investment of time that a bunch of people made, and Eric is definitely very aware of this and others who were there. So I'm referring to the measurement of the basic demographic and social determinants. They should be standardized using the census, using some valid measure of social class, something that we just don't do very well in the clinical world in the US. Researchers do it. We can argue about what's better and what's not, or how did you get that, did you get this, but in the clinical setting, we just don't do it. They do a very poor job, other than insurance, which is collected by the system. But things like country of origin, immigrant, whether you're an immigrant, your family background, people don't ask about families. What did your parents do for a living? That's like a basic question in healthcare. It should be a basic question. I would venture to say, unfortunately, even at UCSF where I was, the majority of our trainees never asked those questions, whether the patient was in the hospital or in the clinic. They thought it might not be appropriate, or you're probing too much, or people might get sensitive to it. But of course, you don't ask, you don't know. And then you get all these other metrics, and we talked about language background and also sexual orientation, sexual behavior. The HIV epidemic made us aware of all the importance of that, so people are much less likely to have barriers about that, particularly in certain parts of the country. But then there's health literacy. What if you give someone a handout, they don't know how to read? So obviously these become important things that we need to learn. And numeracy. We talk about numbers and risks and proportions, and 1% is small, but for the common person, it's like 50-50. 20% for them is small. It means that 4 out of 5 times it's not going to happen. So how can you call that high risk for heart disease? 20%? That sounds low to me. And this is what people think. You have a PhD in epidemiology, you don't, but if food security, etc. So, and then the importance of housing and place, and how do we get metrics systematically incorporated into a health data system to get at that. So I think health IT and the electronic medical record is a tremendous opportunity to do this and do it right. I think that all of us research program, the precision medicine program, will provide us a model that our systems can follow, because the systems don't do it on their own unless somebody, leadership changes it, or there's a motivation to change it. The tools have the capacity to do it. The systems have to say, we want to do it. We want to activate this tool. We want to collect this data. Even basic information isn't collected. There's also an opportunity to do things in precision health care. What about people who are not digitalized in their life? They're afraid of a keyboard. They can't really deal with computers or electronic communications. How do we get to them? And there could be people who don't know how to read, or people who are older, people who have other factors that prevent them from. So we have to look for ways to lower those barriers. Touchscreen technology, videos, things that will make it easier for them to get to. Finally, I'll say a couple things. When is more precise better? We have to ask that question. We can't just assume precision medicine, individually tailored, is better. The assumption is that it is. And I would say you have to prove it. You have to show data that it's better. Now, immunotherapy of cancer, if you have a driver mutation and you have a biologic that will treat that will shut off the replication of cancer cells, that's clearly better for the percent of people who have that mutation. And that's where the precision medicine state-of-the-art knowledge is at right now. That's the only place clinically where it's really having an impact in what we're doing. And precision oncology we should invest a lot more into figuring that out, those pathways, as was mentioned before. But I would say one size fits all can work. And we know it can work. There's outcomes that have improved. And we don't need to have precision, immunizations, for example, or even precision treatment of blood pressure, or I would say even most of the time, precision treatment of diabetes in order to improve outcomes. So I think really we need to think about it. New is not always better, but it's almost always more expensive. And we have to really take costs into consideration. This whole conversation of, we don't deal with that. We don't talk about costs. That's part of what happens at NIH. But as a society, I'm speaking as a citizen as well as a scientist, we have to begin to look at that very, very much so. At what point is, and then the last point on this is precision in the patient-clinician interactions. So the power of that intervention, to put it in those terms, has been underestimated. People do tend to still listen to their clinician, their doctors. Sometimes people do things not because they believe the data that you present them, but because they like you. And they think that you're my doctor, you know what's good, I'm going to do it because you tell me to do it. Not because there's a 20% reduction of cancer if you get the screening test, or if you take an aspirin for 10 years, you'll have a 20% reduction, 25% reduction of heart attack. That doesn't mean much to people, but it does mean that you care about them, that you are relating to them. And so I think this whole precision and patient-clinician interactions needs to be studied and pushed. especially in this era when we're just trying to get doctors to look at patients again in the office because they're too busy looking at the computer to order tests and to document, so they don't have to be documented afterwards. So I'll stop with that.
All right, that was a fantastic panel, and I personally learned a lot and have a lot of great catchphrases to leave today with. I'll start off with a few of them for your favorite television show now, All of Us. Anyone who wants to make a jingle for that, come up with it. Some reminds me of Good Times, we could, so precision medicine is now All of Us. I think also interesting to hear about how some people believe that it's in contrast to this idea of one size fits all, but then we just heard that perhaps this is a false dichotomy, that precision medicine is just individualized and public health is just population sort of level approaches, and that perhaps there's this intersection that already naturally exists between the two, and that we're trying to force this dichotomy that may not exist. This idea of precision medicine as evidence-based public health, I loved that phrase. Very interesting because I do think we underestimate how much we have shown the importance of environments and social processes and how it's impossible for this to not sort of infiltrate the activities that are going on around personalized medicine or precision medicine. I love this idea that new is not always better, but definitely costs more, and I think many of us are going to be concerned with that as we think about whether it really will benefit all of us or not. And so these are some of the things that I sort of highlighted in my notes. But what we want to do first, before we answer questions or do a Q&A, is to hear comments from the audience. Anything that stands out for you, anything that you're concerned about, any insight you may have into where we're going or sort of what the next 5 to 10 years looks like under this All of Us initiative. So I'd love to get the comments, and then we can sort of have more targeted questions for our panelists. We will start with Tanae Lewis, since her hand is up first.
I just want to, Dr. Perez, you talked about the importance of the doctor-patient interaction and being able to collect some of these, ask questions about things that we don't usually ask about. And I feel like there's a tension there. Right? Because the doctor-patient interaction is these days 15 minutes, and we know it's a source of bias for many minority patients, right? We know if you break your leg, if you have a long bone fracture and you're African American or Latino, you're less likely to be prescribed adequate pain meds. We also know, you presented a slide earlier in your first talk where you talked about the importance when you work with minority populations of having this high touch and really being able to interact with them in a way where you get that information. I can't imagine someone sitting across from me for 15 minutes and me telling them what my parents do. I mean, we in interviews have that information at the end. Income is one of the variables that we have the most missing data on, particularly for racial ethnic minority populations. So I feel like there's a tension where we have this system that doesn't benefit, that many people know is biased against them, and there's enough evidence, the unequal treatment report, that there is bias in that encounter, but we want that encounter to then be the place where we get all of the information about social determinants, when in fact that seems to be the one place that perpetuates inequality. And some of that could be because the time just isn't there, but the workforce isn't there either, so I'm just curious about your thoughts on that. Sure. And others. I don't know. Maybe
you did not follow directions.
You got to run it.
That was supposed to just be a comment.
You got to run a great to study. You made
some.
Yeah.
Okay.
I think that a lot of this can be done in a systematic way that's removed from the, the 20-minute visits. When that's number one. So it's not the burden on the clinician to collect and ask all the questions, either self-administered, computer-assisted, or paper and pencil, and then upload it later. There's many ways of collecting this information. And in practice, we would have a questionnaire, and there was a bunch of questions, and then your first visit is prompted by that. why you're here, and you focus on the medical issue primarily, but most of the time as a primary care doctor, people aren't there because of an urgent, my back hurts or my throat hurts. Sometimes that's driving it, but it's really to establish a long-term sustainable relationship with a clinician. And the basis of that, that first visit is an important one to begin to set sort of the groundwork for that. Now, sometimes people will never come back, but most of the patients that I saw as a general internist were there for the long haul because they have diabetes or high blood pressure or some other problem that required them to check in on a periodic basis. So that's the premise of establishing this database. So it also goes to another issue, is the fundamental basis of the health system should be a primary care generalist, family medicine, general internal medicine, and pediatrician, which is not what we have. So that's also a separate issue. So I think it's doable with better system data collection, and I would strongly argue that this is valuable, as valuable as any aspect of the medical history that we obtain. You got to know what your patient is like, where they're from, what they're doing. The problem with minorities and bias is a real one. One of the interventions to address that is to train a more diverse clinical workforce, because it's been shown that minorities do tend to go work with other minorities and Medicaid and uninsured patients. But that's a separate discussion. It's not impossible. In fact, it's very doable for anyone to learn these techniques and to be effective in their... And communication is a very powerful tool that we take for granted. Now, as a researcher, you practice communication. You're writing communication for your grants. You're communicating your results. But in caring for people and helping manage their problems, it's a very potent intervention that we don't know how to quantify often. And doctors and clinicians take it for granted. Well, you're either good or not. It's sort of a gift, and yet it's a learnable skill. And if more you think about how to do it better, the better you can get at it. So I'll leave it with that.
Mario and Bree.
Okay. Mario Sims, Jackson Art Study. Just an observation, so we know that the focus of precision medicine is cure disease at the individual level. Your comments said we need to prioritize it from social determinants and population health perspective, which is what we expect in this type of form. But one observation that I have is that it's interesting that a few years ago we talked about translation, and now we're talking about precision medicine. So it seems that from the translation, particularly the T4 perspective, that you move from the bench to the patient to the clinical practice to the population, from a multi-system, multi-layer, systems-based approach method, whereas in the precision medicine, or the all of us perspective, now you go from the individual level. And we're challenging that to say, well, where's the population perspective? So it seems that there's potentially a convergence of either these paradigms, or is this part of the false dichotomy going on with these two perspectives? And I just wanted to make that observation. I don't know if you might want to comment on that. And so,
does anyone have a...
Well, I think actually one of the big changes that is happening, and it's hard for me to wrap my head around what are the implications, but when the shift to the sharing of electronic medical records, or even hospitals looking at their population like a population, and getting that information now into the, I'll call it practice parts of what they are dreaming in this precision medicine, that's a big shift, because the individual doctor with the patient now actually having more information from the patient population perspective has never happened before. The way you got the patient population's perspective is by having a lot of patients. Right? But now it actually is becoming much more of an emphasis, and it's across the country with different names. One of them is the Learning Health System. And there are big grants by PCORI that are actually sort of set up across academic medical centers to pull millions and millions of these medical records into basically a knowledge grid. It's almost like a different kind of surveillance than what public health has done, though public health actually pulls from those data and has. But we're on the verge of a different kind of population perspective because of the liberation of the information in the electronic medical record. That said, electronic medical record was not set up for epidemiology. Okay? And there are some real, I'll call it, evolutions that need to happen before it can act as such.
The other thing, I don't know if this answers your question. I think it's a very good point, Myra, that you're raising. But the other tricky thing here is that although I clearly see the value of this very large cohort and everything that can potentially be done with it in terms of broad population health research. It's also a cohort of patients, and there's a reason why public health does other things and samples other people, and so I think we need to think carefully about that. And also I'm sure that there are ways the statisticians can help us figure out, well, how can we use this to predict population levels, taking into account the selection factors that get people into the patient population, and who's there and who isn't there, and who's there more frequently and who's there less frequently, because that's all going to have implications too for what we find with this.
So I just want to pull on this. So when we actually tried to get the prototype for the thing I was talking about to get sort of precision population health, having real information on people that are below the poverty line is nearly non-existent. Or it's at such low levels that you cannot make good inferences about it because they don't have insurance, they don't have good relationships with clinics, they're not actually in our studies except for a small handful. And so there's a huge part of the population that we're missing and don't have a good way. They're not going to show up in the precision medicine initiative.
Reed is just doing it.
Speak really loud, Bree. We can't hear you.
Oh, I'm sorry. Sorry. My name's Brianna Messick. I'm here at the University of Michigan. And my question is about how does personalized medicine intersect with something, Eliseo, that you said during your talk in terms of what is the best treatment to kind of be preferred, right? Our goal is not just to sort of handle individual diseases one at a time, but rather to improve quality of life for people, right? That's the job, it sounds like, of precision medicine. But when we look at precision medicine, it's like, well, what drug reduces blood pressure by more points for certain, you know what I mean? It's like it's one outcome at a time, and we don't have a conversation, or I guess I'm asking, what is how does that sort of treating one disease at a time rather than the person with whom may have to take 15 medications to manage all of these things that are happening, is that the preferred outcome? And how does precision medicine handle that? Like how does precision medicine intersect with the goal of medicine, which is not just to manage disease, but to promote, or if that is the goal, right, to promote health?
Oh man.
Well, I should clarify that the term precision medicine, I think, has been maybe overblown a little bit, and from what I hear here as well. And this cohort study, this All of Us research program, if it does happen, which I hope it will, is really a research platform for the future. That if you collect data in a systematic way, both the social determinants, the individual behaviors, the demographics, as well as store biological samples. I think they're going to collect urine. Eventually, they'll get at the microbiome somehow. Maybe not in phase 1. And it's going to be, and if it works, it's going to have different levels of adding stuff to it for future discovery. Yes, it is a cohort of patients, but there's actually a volunteer website that anyone can join. And the idea is that this is not only for patients, but that you use different clinical sites. They're banking a lot on the community health centers to get at poor people. I argue that poor people also go to regular places, and working people go to places who have insurance. So I think it's going to be a mix. But you're right, the delusion, and I'll say it's a delusion, of some scientists was that you'll come in, I'll have my genome or my biological data, it'll be there in front of the doctor, and the doctor will be able to say, okay, your blood pressure responds to this, or your diabetes will respond to that, or your pain will respond to this drug because of that receptor. I mean, that's a little bit of Star Trek, you know, and you know, the future. Maybe it's going to go there. I don't know. I think eventually we'll be able to use all that biological information in a better way than we are now. But boy, it's far from that now. It really isn't, except for cancer. I think cancer, it's happening now, and it is, I think, a challenge to how do we do that. But you're right, comorbidity and multiple chronic diseases is not what NIH institutes thrive on. They do one thing or two things. And so I think that's, some of that intersection gets picked up by National Institute on Aging. You know, we have some role in that. I think there's more acknowledgement of that. And, you know, what about cancer survivorship? You know, most people, I mean, cancer used to be like you died, right? I mean, there was not much treatment. Now, the leading causes, except for lung, you know, but prostate, breast, and colon, people actually do pretty well. Who takes care of those patients? What are their risks? How do we manage them when they get diagnosed? You know, so there's all this stuff going on that is not NCI only should be worried about this. It's a bunch of other scientists, and we need to integrate more. And I think that's the role for multidisciplinary approach. I think disparities by definition is that. And again, going back to the healthcare system, is a great role that the generalist deserves in a better functioning, better organized healthcare system.
So thank you for that. So I'm just going to ask a question and then I'll open it back up to the audience. So I just wanted to say thank you to our panelists for this really excellent discussion. And I read a quote that said, precision medicine is a mistake and a distraction from the goal of producing a healthier population. And I think that all of you have kind of shown that actually expanding precision medicine into something that's more of a population base is sort of the way to go, and that's already happening. And so my question as a more biological epidemiologist is around the role of integrating biology with the social aspects. So for example, we know that genetics hasn't really done as well in terms of prediction, but it's done pretty well in terms of showing us a little bit more about etiologies and disease pathways and things like that. And I envision that other kinds of omics like metabolomics and the epigenome, which we know sort of can act as a bridge between the social and the disease outcomes. I sort of see that sort of helping in our precision and understanding. My question is, do you see that these new biomarkers as acting as in helping us have precision in action? So for example, if you had an epigenomic map of the United States where you could sort of see how biomarkers were shifting in different demographics and different locations, would that be a useful public health tool? And then my other question to that is, do you think with the new technological generation that having information about your own biomarkers and being able to compare them with your neighbors and will give people sort of this knowledge as power and more, and would it cause more of a sort of a grassroots, drive toward pushing for better policies and better public health care? So are those ways that the omics can sort of help in this scenario, or is that just my pipe dream?
That's a whole symposium on it. I mean, what a great set of questions. I mean, I think there's a couple of pieces. One is that the epigenome actually is showing us things, I'll call it more in aggregate than we had sort of anticipated. I mean, I know its relationship, for instance, with chronological age. This sort of biological aging metric actually could be also used in terms of I'll call it indications of fragility, or ways in which physicians or even the person has to pay more attention because their epigenome is signaling that their whole body actually has aged much more than their chronological age. So some of it is giving a better indication. The whole genome information thing in the handheld device of a 22-year-old or a 42-year-old, I mean, it's going to be there if we do it. I mean, especially if departments of health start to do whole genome sequencing of newborns for inborn errors of metabolism as a part of newborn screening, it's going to get there, and it's going to get there quickly. So now doctors have got a different issue, which is people come with that and a Wikipedia about what they want and what they think, and there's huge misinterpretations because not all mutations are alike, and not all genes are alike, and so I'm hoping somebody else will take that on.
Well, maybe yes. Where do you get the biggest bang for the buck, right? I mean, we just heard that, for individuals in our communities, hearing that you have a 20% chance of having a heart attack over the next 10 years, is not a particularly good motivator to, say, change your behavior, stop smoking or whatever it is. I believe Dr. Perez-Stable mentioned that maybe that's more dependent on your interaction, the quality of your interaction with your healthcare provider that induces you to make those changes. So now we have my own genome that predicts what, 1 or 2%? And that somehow is going to be helpful for individuals to make health-related decisions. I'm not quite sure how that's going to work. And you juxtapose that with certain things that predict risk, which, with a much greater probability, poverty certainly being one of them, how do we think about this, as a useful tool for people to make better health decisions for themselves? So I have a hard time seeing that anytime soon.
I can jump in here and add something. So I see, generically speaking, I see 3 uses of biological information: genetics, epigenetics, omics, whatever. One is, sometimes it tells us something we didn't know before. So it can tell you something about, a cause and effect process that you didn't know about before, right? I don't know, something in the environment turns out affects your epigenome, and hey, we didn't know it affected health, and now we know that. So it tells you something new. And those cases are not that common, but they can exist. Another is it simply helps strengthen a story that we already know. Like, we already know that, social circumstances affect your risk of cardiovascular disease. But having that mechanistic confirmation through effects on the epigenome somehow, gives it a little more strength, and therefore justifies potentially actions that we already knew we had to take anyway. I mean, no, really, but it legitimizes that, and that's good. That's useful, right? Or it helps complete a causal story that we needed to really make the case. And I think a lot of it, I would say, probably falls, at least in my sense, a lot of it falls under that realm, and that's for mechanistic understanding that helps justify. And then a third thing is that, for whatever reasons, we can have a discussion about why this is, in our society, biological information carries a lot of weight and can be very empowering. So if you show, in some ways it's a sad commentary on our society, but if you show that poor kids have, you do a scan of their brains and you see something there, it's like, oh my God, we already knew that they were affected, but it creates a message that can be empowering for advocacy. And so I think that's also a very important, use of biological information. So I think in those 3 things it can be helpful.
I think the sharing of data, we'll jump in here just as a quick, if we have time. The sharing of data, I think that technology isn't going to solve everything, but in terms of precision medicine, There's a small story about there's a student, I think it was in Michigan actually, who wanted a general do better at exercise. Didn't get more physical activity. That's a general population health kind of a message. So she tried running, didn't keep up with it very well. Got her iPhone, got an R scraper, figured out, okay, if I run in the morning or the afternoon, which do I do better at? Oh, if I run with these friends versus those friends, do I do better at that? Made her own little micro trial of her own personal kind of activity to figure out when she was actually going to change her behavior. And successfully then, lost a bunch of weight and did all the stuff we need to do. I think that's the part of precision medicine that can be very useful, right? The tracking of that data,
So
showing it, just what you're saying,
back
right?
to the person.
It's been shown
Yeah.
if you measure your body weight, the people who do lose more weight and keep the things. Take that same and turn it into more of a medical kind of a thing. There could be genes, there could be variants that affect the way that you would respond to a beta blocker versus a different type of hypertension treatment. But if we send the patient home with a Bluetooth-enabled ambulatory blood pressure machine and we put them on what we think generally has worked in clinical trials, it may not work for that patient, but we can change their treatment modality faster if we monitor that and get automatic algorithms for saying, okay, if the beta blocker's not working, we put them on the next level. And if these three aren't working, add a fourth, or decrease the one that's not working. That's where I think the personalized precision medicine component could be useful. And then it comes into how do we then help with health equity by getting the technology available to more people, because that could, as one of you guys originally said, you could actually increase disparities if we start moving to that modality for treatment and only certain few have the access to those kind of technology. So there's one point. I think one other quick that Sharon was kind of going crazy on when Carlos was talking, 1 to 2% of the genome, yes, but for certain things, take diabetes as the simple, right? Type 1 diabetes, 90% genetically related, right? Type 2 diabetes, who knows? 5, 10, maybe it's a. So there's a part of our statisticians, we love the phrase, it depends, right? It really depends, right? Because if you've got the gene, oh my God, that's super huge effect, but only a small portion have the gene. So that's not to say it's not important. It's to say the more we learn and the more data we have to collect, the more we're going to be able to do better at precision medicine. I think that's just my perspective.
Thank you for that.
That's great.
Important comments. So one of the things that I want to do now, and I actually see my student raising her hand, so we're very connected here. I'm having a proud mentor moment, is to turn it over to the graduate students so that they can have an opportunity to share their comments, questions. Some of us who have been here for a while kind of just jump in, but we want to also allow an opportunity for you to hear from the panelists and to ask your questions. And so I'll start it off with Rashida in the back, and then others will follow up with you as well. Can you speak up some?
Oh, yeah.
So you have to speak louder than that.
There you go. My name is Rashida Brown. I'm Mahasin's doctoral student in the Division of Epidemiology at Berkeley. My question / comment is that data is going to be the driving force between this, the driving force behind the precision medicine initiative. We're going to have data at a much faster veracity, larger volumes, and a lot of different types of data sources, like the gentleman here is pointing out, things from your iPhone tracking to GIS-based measures and other things. So my first question is, to what extent do you believe that the researcher should be driving what variables are in these algorithms? So if we find that these neighborhood predictors are not the best possible predictors, should we still include them in the algorithms? And also, to what extent do you believe that personal biases could play a role in use and potential misuse of these precision medicine algorithms?
Boy, go ahead.
The researchers, as they say in English, the horse is out of the barn, right?
Yeah,
it's already happened.
Yeah.
So the basic variables that are being collected in the initial phase that pretty much determine they're good. I mean, if you the starting point for the surveys is in Haynes and HIS and so it doesn't have everything everybody wants, but it has all the basic stuff. I think in a database, if you find that some factors aren't contributing to the outcome that you're interested in, you either take them out of the model or you don't weigh them, right? So, I mean, there are some things that I think always need to be in there, but most of the time you just don't consider them if they're really not influencing. So I don't think that should be a problem in analytic models from researchers. What gets out as would be consumed as policy or changing healthcare or changing public policy, and that's another matter. That's a little bit more longer. And I want to emphasize one point related to the earlier comments, is that we also should be looking for resilience or for the ways to decrease barriers, the positive things. Not every person who's poor does poorly. It's like the old thing is not every smoker gets cancer, right? I would say, well, they all get lung disease, right? So I think we got to also look at the value of these kinds of data to find the positive pathways, not just the ones that lead to bad outcomes. So.
I think the other thing I'll add is actually using what is already there as a launch pad. It's like expanding upon what is already there is one of the best techniques for getting your grants done, forwarding the science, and especially with the ways in which they're collecting information. If the technology is already built, what is that one twist that gets you what you want in your cohort or your community? Build on it. Don't recreate the wheel.
Saw someone here?
Yeah,
yes.
My name is Ana Ortigosa. I'm from Drexel University. I think you hit it a little bit. What my concern is, I understand precision medicine. You are trying to, in population-based information or some kind of social environment information addressed to probably improve the clinical outcomes and how we practice at the clinical settings. But my concern is in terms of how the counterpart of having more information about social determinants could be contributing to stigmatization or reproducing stigmas. So my question to everybody in the panel is, if you think how are the strategies to keep more awareness to the researchers, but also how we translate that to doctors or healthcare professionals that are in the close relationship with patients. How does this not mislead our aim to have more and broad information, and this is not trying to address a kind of healthcare for poor people or constraining more the options for people that is vulnerable? Thinking in terms that this is more reproducing the risk pattern or the risk model that we have, and not pointing out or giving more strategies for resiliency in patients in vulnerable conditions.
That's a good point.
No, that's an excellent point. I was part of a CMS project to actually think about how to add measurement, at least, of social determinants to routine clinical assessments. And this definitely came up as one of the, what they call unintended negative or adverse consequences. Is, if we start collecting information on social determinants, that may have not only potential consequences for stigmatization, for maybe healthcare providers, changing their clinical routines as a result of knowing the social determinants. It may also become part of healthcare systems avoiding certain populations because they are measured with these performance criteria, as we heard this morning, and reimbursements, certainly from CMS, are dependent on these performance criteria. And so these are very tricky issues. And I will say, sometimes we hear an acknowledgement of the importance of social determinants in clinical care and healthcare outcomes, from perspectives, from angles where there hasn't been given sufficient thought to what that exactly means, how to do this, and what the potential consequences of that is. And this worries me sometimes. So social determinants are important. Let's just add income and education information, and we're done. Thank you. And it's not that simple, and it takes people like many of us who have been trained and worked with social determinants to inform our colleagues, it's not that simple. you know, you have to think this through. And there's actually a whole science behind it, believe it or not, even if it seems like common sense. And it's sometimes hard to convey that. And thank you. I think you're right on the mark there.
There are people that are thinking about that information in terms of the response to it. So it's not just within the patient-physician interaction, but what are the wraparound services? What are the ways in which that information actually gets, I'll call it, better care and continuity out into the communities? I think one of the visions of community health workers was that bridge, so that what is happening is that when the information can be helpful, now use it in that way outside of that 20-minute, I'll call it, incident. And that actually is a whole other kind of interstitial space in healthcare and public health that we've not explored. There's a huge gap between medicine and public health that we've got to fill somewhere. And it could be a link, but it could also be a black hole, depending upon whether or not we build it.
So we're almost out of time, but I did see, DeMarc, you had your hand up, and I didn't want to not get back around to you. So do you want to ask the final question?
Just have a couple observations and potential other things to think about in regard to perspective from community. And so I think that with precision medicine, I can get it and understand it, but then when you tell an individual that you have this genetic mutation or something, so how do they then process that, especially if we think about the low health literacy rates? So does that then bridge in other public health professionals or other professionals such as case managers and navigators, and now trying to have that harmonization among or across these words or these terms? So how does that really get implemented in communities? And so then the other piece is, I see that NIH also has this call for proposals out for communities to help recruit in precision medicine. So that always gives me a pause right there, because now you need people to come in and bring community to the table to participate in these types of studies, particularly low-income communities. So we even see that in Jackson Heart Study. We use HBCUs to try to bring blacks in to do genetic testing. So we have all of these medical mistrust things that are happening. That's why we have to bring these people or these individuals to the table. So then we bring them to the table, and now we have all of this genomic, genetic, precise medicine type things. We know we have this mutation for this. We see SNPs for hypertension that causes or says why blacks may have higher rates of hypertension and poor control, or we have pharmacological advancements like lisinopril, very cheap, but there's higher rates of African Americans that have allergic reactions to that, but it's very cheap. That's why physicians prescribe it. But then we still see high rates of blood pressure control, even resistant hypertension. So then the other concern I also see is there's even House resolutions currently now that talk about genetic testing and that they can be part of volunteer wellness programs, right? So if we have all of this precise medicine and this information is now saying, well, we can identify disease even on these genomic pieces, then what, and with now this repeal to Obamacare, how does that start looking in these data being put in hands of a majority or supermajority that can truly impact people's access to health insurance or even potential discrimination in terms of employment? So I get it and I can see these particular things, but I also see from the other side that these new things can actually be damaging to society.
Let me reassure you that at least in this research study, the All of Us research study, I mean, it's the confidentiality of research, as any of you do with your participants, is identically applied. That the genetic information is protected, much like the certificate of confidentiality that is being used for substance use or illegal activities, and actually documentation status is protected as well in the All of Us study. So I think that there are legal factors in place that will protect the research participants. that doesn't preclude people from misusing the data or analyzing the data, but at least it will be de-identified. And how, you know, how that gets interpreted or analyzed, it's really going to be up to us as scientists to monitor and evaluate that. So, but I don't think that we need to worry about it becoming used against people because we identified you. There is a bill, I think maybe you referred to that. There's a bill that has gotten some notice that employers will be able to require potential employees to get genetic testing so that then they would be charged a higher rate for their health insurance. And there's no, at least the Secretary Price has made a comment that seemed that he wasn't in agreement with that. So I don't know what the future is. But people are talking about this kind of stuff. So we have to be on the lookout.
I was going to say, as a country, we've got a long history of messing up on genetics in this way. We got a long history. And you know, many people don't know that, you know, Public Health Service, when it started over 100 years ago, only had 2 programs, immunization and eugenics. So I really think that there are hazards when scientific advances really get out of sync with social advances. And so, and there's a way in which we've got to do both simultaneously, or it does actually come back and bite us. I mean, there are countries that are doing screening for IQ genes and, you know, prenatal screening. IQ genes don't exist. But they think they have them, and they're doing them to select, you know, children.
Gene editing technology.
Gene editing technology. I mean, we've got to work on the social while we're doing all this genetic.
Yeah. So I just have one quick question. With all of the hope around the research in precision medicine, especially as it relates to public health and population health, is there something going on hand in hand with medical training? Because all of this information will be put in the hands of doctors, and if nothing is changed in the way that physicians are trained, it leads me to believe that the use of the information really won't be taken advantage of in a way that can be as effective as it would be. So I'm asking, is medical education keeping up with precision medicine?
Cleo is always ahead of things.
You know, I think there's 145 medical schools now in the U.S. They vary a fair amount. I was at a medical school for 37 years that I think in many ways was one of the leaders in curriculum innovation. So I'd like to think that it is, but it's probably a biased sample where what is going. Is so much information that it's not really about the information. You know, you have it at your hand, right? You have it here. If you need to know something, you look it up. It's really about an approach. It's about communication. It's about how to factor different things in. Most of the time, you don't need to make snap decisions about things. And for people to give time as a diagnostic test, there's a lot of other factors that go into this training. And working as a team with other healthcare professionals becomes very important. Now, public health hasn't been incorporated into it yet, but I think a little bit with this population health perspective that is relatively new. It's a consequence of the Affordable Care Act. It's accountable care organizations. Of course, Kaiser was doing that 50 years ago, and I think that they're a standard that we can look for in health to do this. But now, at least in California, that's all that people are talking about. Not true in the Northeast, at least not what I was able to do, not in the area where I'm in now.
So what prompted my question, I recently met with a young medical student, and she was trying to decide whether or not to get a master's in public health, because she was interested in communities and relating to patients in a different kind of way. And with that background in public health, she felt her education would be more complete, because what she was currently getting in medical school wasn't exposing her in the same way to the kinds of things that we've been talking about today. So that's why it prompted me to ask that question.
Right.
Is there something in the planning in the future where physicians would be trained to incorporate some of this thinking?
I think what you're seeing is that people who have that interest, yes, it would be a 5th year, so it's more debt. But you can also make the argument that some people need to go to business school, and some people should go get a master's in education, and some people might want to do something that's more basic, and combine an MD, PhD with basic science or with epidemiology, if they're going to do research. So I think it can't be a single pathway. And taking a whole year for doing an MPH is great, but I think it's hard to say that every medical student should do that. Some of the basics need to be incorporated in the curriculum as it exists now.
Right, but my argument had to do with if precision medicine is a vision for healthcare for the future, it seems like it should be in the medical schools where that training occurs.
Okay, I think
sorry.
I'll tell AAMC.
we're getting the evil eye, I think, from Amanda, so we need to wrap it up a little bit.
The conversations can continue.
Absolutely. Yes, and thank you so much to our panelists.